Hello and good morning and welcome to the Alabama Public Training Network. The 2014 Ebola epidemic was the largest in history, affecting multiple countries in West Africa with relatively weak healthcare systems. Today, we will hear firsthand account from a pediatrician physician about what it was like to work inside a treatment unit. Thank you for joining us, Dr. Baker. We really do appreciate your time. Join us this morning for Ebola Response in West Africa, My Experience. Dr. Baker, welcome.
Well, thank you for the invitation to speak on this topic. I'll just mention a few things before I get going. During the time that I worked in West Africa, I was a paid employee of Partners in Health, which is a not-for-profit charity. I worked for them for 9 weeks, so I'm no longer employed by them. I won't talk about commercial products or services and or FDA non-approved products providers. So I'd just like to say that the thoughts and opinions I have are entirely my own. They're not any of my employers necessarily, or other organizations, including the federal government that I've done disaster response with. We have four main objectives. The first one is to identify the four key elements of the international response to the West African Ebola outbreak. And then we'll talk about the purposes of an Ebola treatment unit. So why treat Ebola in a specialized unit? And I'd like to review some of the ethical challenges in taking care of patients in this environment. So especially what I learned. And again, I call this my experience because I understand that everybody has a different take on this topic, and there's really no one right answer, but there was a lot that I learned about it, and I hope to share some of that with you. The Ebola virus disease is caused by a single-stranded RNA filovirus. It is similar to other viral hemorrhage. It is a viral hemorrhagic fever similar to Lassa and hantavirus, which is present in the U.S. Four Corners area. It's a zoonoses, meaning it's something that we share with animals. So it's an infection that animals transmit to humans, and so they harbor it and can spread it to humans. That's the case for most emerging infections. The incubation period for Ebola virus is 2 to 21 days. Typically, it's on the order of about 4 to 10 days. Diagnosis is by a real-time reverse transcriptase PCR test, which in resource-rich settings like the U.S. might take about 6 hours, but in West Africa can take upwards of 3 days. The case fatality rate for Ebola virus is historically around 83%, so it's an extremely serious, deadly disease. And most patients who die from Ebola appear to die from hypovolemic shock and multi-organ failure, typically within the first 2 weeks after they contract the illness. Again, I mentioned that it's a zoonoses, so there's what's called a enzootic and an epizootic life cycle. Animals spread it among themselves. The reservoir is thought to be bats in West Africa, probably insectivorous bats, perhaps fruit bats. And they transmit it among themselves, and some of them can then transmit it to other primate animals, like the orangutans and the great apes, and also forest deer, the duiker, are another reservoir. So at some point there's a spillover event that occurs in which animals transmit it to humans. It's thought that there's only one of these that happened for the West African Ebola outbreak, and the main hypothesis is that it was a 1-year-old child in Gekidu, Guinea, who contracted it from playing in a tree stump that harbored bats. The child then transmitted it to the family members and subsequently to community members. All of the remaining transmissions were human to human after the first initial spillover event. Because of weak healthcare systems, from December of 2013, it really went undetected for several months. and was spread throughout the whole region. And by March of 2014, it entered Liberia and Sierra Leone. The following is the months progressed over summer. By August, there had been upwards of 3,000 cases of Ebola virus disease with 1,500 deaths. So at that point, the NGO organizations, primarily Doctors Without Borders, that was taking care of patients in these countries, had exceeded their abilities to care for any more patients, so they were having to turn patients away. So the fear was that as patients were left untreated, that it would escalate. So at that point, World Health Organization declared a public health emergency of international concern, which recognized that the virus had spread across international borders and had reached the point where it could not be contained or managed by these governments and these health systems alone. So international resources were needed in order to address it. So that happened in August, and at that point case numbers had started to just skyrocket. Prior outbreaks of Ebola were limited in geographic locations, primarily to rural areas of Africa, and I think the largest number of cases prior to this outbreak was about 300 or 400. I think there have been 26 prior outbreaks, 25 or 26. So this was way more serious and larger than other outbreaks. What you'll see with Ebola virus disease is a progression from what we call early or dry symptoms, which are fever, nausea, fatigue, and then as the viral load increases, late symptoms start to occur after about 4 or 5 days, and these include vomiting, diarrhea, coughing, and bleeding. Early on, during the early symptoms, patients aren't contagious. So if you're not having wet symptoms, the feeling is that you're generally not contagious. So early on, patients aren't contagious. They feel like they have the flu, or they feel generally just fatigued, sometimes fever, but that's variable. And as they get sicker, that's when the viral load increases, and that's when they're most infectious. And death generally occurs within about 10 days or so. The corpse is highly contagious, so people will excrete it in their sweat glands. This is from a New England Journal case report on a WHO worker who was evacuated to a special pathogens unit in Germany. And what you'll see here, I'm sorry you can't read it, this is probably too small, but you'll see that the amount of vomiting and diarrhea by about 2 weeks into the illness is upwards of 8 liters a day, so that's over 2 gallons of fluid losses daily. So here this patient had a central line and received critical care, and actually had a good outcome. But this type of fluid losses where patients are just losing lots and lots of fluid is very typical for Ebola virus. What you'll also see is that as the viral load of Ebola virus starts to rise, it triggers an immune response, and that as patients' antibody levels increase, the viral load will decrease. So experts interpreted this to mean that if we can support patients long enough for their own immune system to kick in, then they'll have a favorable outcome. Again, I'd just like to mention that all these handouts are posted online, so if you can't read them or you want to pull them up, or you want to check the references, they're all available online. So that's a little bit about the science behind it. And again, the science is really limited on Ebola virus disease. Most of what we know is because we brought sick patients back, primarily healthcare workers, back to the U.S. and back to Western Europe so that we could treat them. And in the process of treating them, have learned a lot about this disease. So a couple things in terms of public health issues. I'd like you to know that Ebola virus disease is a disease of caregivers. So the way that you get Ebola is by caring for other people. So the risk groups in West Africa are people who take care of others when they're sick. And that means adults, primarily mothers, but also grandmothers and grandfathers. and then traditional healers, and also religious workers, people who are involved with funeral work. So priests and imams and traditional healers. So those are the main groups, but also healthcare workers. So it's a disease of caregivers, and it's also a symptom of weak health systems. So you don't really see big Ebola virus spread in other countries that have stronger healthcare systems that are able to do disease surveillance, able to follow people, and able to detect it too. So the reason we need to treat Ebola in a specialized unit is that traditional healthcare settings like hospitals, health clinics, amplify serious pathogens. So we've seen this with SARS, we've seen it with MERS, we'll oftentimes even see it with influenza, things like that, where you bring people together or where sick people go and are in contact with other sick people, you'll see an increase in infections. And that's what happened with Ebola in the U.S. So the only 2 cases that were transmitted in the U.S. occurred in a healthcare setting, and that was after Mr. Douglas was identified. He did not transmit it to people in his home, again because during the dry phase, the early phase, you're not really all that infectious, okay? But once you have wet symptoms, like when he was in the hospital, that's when the 2 healthcare workers, the 2 nurses in Dallas, contracted Ebola virus. So what happened in West Africa by summer of 2014 was the healthcare system in these 3 countries had really just imploded because healthcare workers started to die. Foreign missionaries had to leave the country because it was no longer safe to treat it. And the response was really to set up specialized treatment units. And these are probably best thought of as specialized infection control and prevention units, where there's one entrance for patients to go in. Patients who meet the case definition are then tested in the unit. They are separated based on their risk status for having Ebola. So if they have dry symptoms, they're kept in the suspect ward, so dry symptoms. Or if they have wet symptoms but have not yet had a confirmatory PCR test, they're kept on the suspect side. When they are confirmed by PCR, they're moved over to the confirmed side. So within the suspect side, we try to separate the dry patients from the wet patients because the wet patients are felt to be the most infectious. So these are specialized infection control and prevention units. So 3 main reasons why you need to treat Ebola in a specialized treatment unit. The first one is to isolate patients, to get them out of their community setting so that they're not transmitting it to their family members or to people in the community. The second one is really to protect healthcare workers so that people who are taking care of them aren't getting Ebola. So to decrease nosocomial infections. And the third one is to provide treatment. So those are the 3 things that we try to do at these. These are really resource-intense environments, so they take a lot of staff, a lot of water, a lot of resources. Everything that goes into these units has to be burned at the end of the day. They're very, very resource-intense environments.
On your personnel, as far as working through each one of those scenarios there, did they spend a 4-hour block of time, 10-hour block of time? What was the amount of time that you saw your personnel having to rotate through?
Typically we did about an hour, maybe 2 hours, depending on the conditions, but ideally about an hour. I'll speak a little bit more about that in just a second, but I kind of wanted to just go over the design of an Ebola treatment unit. And again, it's not really the structure that's important, it's rather the design. So these could be tents or they could be retrofitted buildings. So before I left, I kind of took into account some considerations. First was the motivation, why do this? I've been involved with disaster and field response activities for quite a few years and had been following this on the emergency physicians group website and getting emails about it. And so, but basically it kind of disturbed me that that there seemed to be such a difference in ability to care for patients. So these people wanted the same things that we wanted. You know, they don't want to be sick and they want to get healthy. But yet, due to barriers, not having enough doctors or nurses, not having enough supplies, they weren't able to do it. So that seemed to me unfair. So that's why I volunteered. So in doing so, I kind of made a risk assessment. And at the time that I was thinking of doing this in early fall, the best data was that there were 3 infections in temporary or short-term foreign health workers, so people from the U.S. and Western Europe who went to work in these units, 3 out of 700. So, you know, not a high risk by my calculation, but you know, not a non-zero risk either. So I had to take into a fair risk assessment. And then I applied through USAID's Office for Foreign or International Disaster Assistance, put in my application through them, and they put me in contact with 3 NGO organizations who were still taking volunteers or paid positions. And I got support from my family. They were very supportive. And also my work was very supportive too. I did have to get released from my faculty position to do it. And that took a month or 2, and then health clearance, getting extra shots and all, took another month or 2. So I went with a group called Partners in Health, which is one of about half a dozen NGOs or so that were providing care in the field in West Africa. This is a Boston-based NGO. It was founded by Paul Farmer, who is an infectious disease doctor and anthropologist at Harvard. One of the things that I liked about the group is, they have sort of a belief that healthcare is a human right. So it's on all of their material. And the idea that everybody deserves the best health care. So a couple things kind of fall out from the idea that health is a human right. One is that if health is a human right, then people also need access to the determinants of health, things like food, water, education, the things that make people healthy. And the other thing that falls out from that is that governments are important. And Partners in Health works with governments because governments are the social structure that can guarantee and protect rights. So they protect people's rights, including the right to health. And so those are 2 things about the organization. They made a 30-year commitment to Liberia and to Sierra Leone to be there to help strengthen their healthcare system, so even after Ebola is done. Wow. So I went to Sierra Leone, which you may not know about it. I didn't know about it. But a West African country of about 6 million. It's about 2/3 the size of Alabama, if that helps anybody here. It is, historically, it was a center for the slave trade. So if you've seen Amistad, the slaves that were taken from Africa came from Sierra Leone, and after the Supreme Court ruled on their status, they were repatriated to Sierra Leone. But following the slave trade, which was subsequently abolished, they had about 150 years of British colonial rule, followed by a 10-year civil war that left about 2/3 of the population displaced. So what you found in these countries, all 3 of these countries, is a very highly mobile population. They have relatives all over the region because of the refugee status, is one reason. But also a historical distrust of foreigners, due to the long legacy of colonization, slave trade, and extractive industries, things like mining, diamond mining, and palm oil production. A couple other facts about Sierra Leone. It is one of the poorest countries. After the Civil War, most of the doctors and healthcare workers left the country. So you'll notice the difference between Denmark, which is a high resource country, and Sierra Leone, a huge difference in the number of doctors. But also you'll notice that the life expectancy is so much different. If you look at Sierra Leone, the life expectancy there is 46 years. You have to go back to World War I to find a time when the U.S. had a life expectancy that low. And probably a lot of this is, some of it is nutritional, but a lot of it is because the healthcare system is just so weak. The other thing that you can notice on this graph is that they actually were spending a fair amount of money on healthcare system. But if you're a poor country, it takes a long way to go. If you start off at the bottom, like they did coming out of the Civil War in 2000, to make much of a dent in your healthcare system. So in terms of performance measures from this WHO report, Sierra Leone actually ranked last among 191 countries in 2000. They were starting to rebuild their health system, but again, when Ebola hit, they still had a long way to go. Okay, one of the things I wanted to talk about is the pillars of the international Ebola response. The first thing is case management. That's taking care of patients who are sick. So WHO is the lead agency on that. The second pillar is case finding, laboratory services, and contact tracing. This is the epidemiology behind tracking down who has Ebola, who's at risk for it, and following those patients. And then the third is providing safe and dignified burials, because unsafe burials likely accounted for 70 or 80% of the transmission in West Africa. So providing people an alternative was one of the main means to decrease the case numbers. And then finally, engaging the community in the response efforts. Getting buy-in, obtaining social mobilization was really critical. Getting people to change their behaviors with respect to hand washing, caring for sick patients, and communicating with authorities when they had sick patients too. So before I left, there was a bit of a media controversy on the limits of care in these resource-limited settings, with Doctors Without Borders, or MSF, advocating for a more conservative approach, so to speak. So stating briefly that IV therapy can be dangerous, that many of these patients are very sick and confused, altered mental status, and that IVs can put healthcare workers at risk. The group that I went with took the approach that these patients, these people deserve the best health care available. They deserve no less than we would if we were in the same situation. So advocating for IVs for everyone, more aggressive fluid resuscitation, including like intraosseous lines if available. So I left just after the first of the year, which was kind of worked out with my employer and family. So just after January 1st, I left. We went to Boston for 2 days and did some training. And then I went to Freetown, which is the capital of Sierra Leone, for 3 days, and then was moved to the work site in Port Loko, which is in the northern district of Sierra Leone. We did training at the National Stadium in Freetown, and they had sort of a whole curriculum developed by WHO. We covered topics like hygiene, hand hygiene, avoidance of contact with people. So instead of shaking hands, we would bump elbows. A lot on case definition, because the case definition really separates who needs to be evaluated for Ebola from who doesn't need to be evaluated for Ebola. Because once you bring people into the unit, you expose them to a certain level of risk. So for the case definition, you really need symptoms plus an epidemiologic contact. Okay. We spent quite a bit of time on donning and doffing. We know that doffing is really the main way that healthcare workers get exposed to Ebola. And this is all protocol-driven care. because it's really hard to individualize care in these settings. We worked off of protocols. And then how to rule somebody in, how to rule them out, how to know when they can be discharged from the unit. Also talked about teamwork, mental health issues, among ourselves and then also among patients, how to deal with heat illness. And then we used there was a simulation center where we actually had a simulated Ebola treatment unit where we would spend time in there taking care of patients who had sort of classic presentations, and how to deal with altered mental status, how to deal with palliative care decisions. All those things kind of came up. Following training, we did a couple days of hot zone training at the place that I wound up spending a month at, and that was it was called Maforki Ebola Treatment Center. It was a center that was run by, established by, and staffed by the Sierra Leone Ministry of Health. So it was really their facility, and we came in as to augment their staff, to provide sort of content experts, as it were, and help, primarily in terms of like skilled staffing, nurses and doctors. So this is saying outside the center. It's in Creole, which is English kind of mixed with local dialect, and it says, "Together we will fight Ebola so that it comes out or leaves Sierra Leone." So it gives you an idea of kind of communication issues too. Most people spoke Creole, which you can kind of understand a bit of it, but it's difficult, I also spent 5 days working right on the border of Guinea at what's called a community care center, which is a place where kind of a more rural setting where patients would go, or people would go to get evaluated. If they are positive for Ebola, then they're transferred to a treatment center. But having said that, we still did treatment at these centers, and this one actually was open longer than the other one because the Center for Infections kind of migrated west towards the Guinea border, northwest. So these are 3 graphs from WHO situation reports showing the epidemic curve, so the number of patients. What you'll see is that Guinea is kind of smoldered along. Guinea still has cases, so it's still not over, believe it or not. So for the last 5 weeks, they've typically had 3 patients a week. So there's still transmission chains in Guinea. Just below it is Liberia, where Liberia kind of spiked early on. They had a very robust social mobilization effort, and were able to get the message out pretty quickly, and cases declined rapidly. So by the time I was there in January, Liberia was having just very few cases, but Sierra Leone was still smoldering and was still having a declining, but a lot of cases. So Sierra Leone's at the bottom. So in January, we were typically seeing the country was having about 200 cases a week when I got there, which is down from a peak of about almost 600, but it was still quite a bit. And you have to remember that prior outbreaks, the most cases ever was 400, right? So this is a lot. So it's still a lot. And when I was there, I apologize for how small this map is, but if you'll see the big dots in the center, that is the corridor from Freetown, Sierra Leone to Conakry, Guinea, and that is really where the epidemic had become localized, and that's kind of where I was working, right in that center. The first pillar I talked about was case management. So this is, I think, the only picture of me in the unit. We were really discouraged from taking pictures, and obviously somebody else took this because I'm kind of doing the Ebola pose where you hold your hands down here. And the main reason we do that is so that you're not tempted to scratch your nose or do something like that, to keep your hands out of your face. The other thing that you'll notice from this is that it's all teamwork. So we work in teams. Everybody watches out for everybody else. You have to kind of notice things around your environment. this was a retrofitted vocational school. This is the Maforky ETU. We did protocol-centered care. This is from a New England Journal paper where they outline their care protocol. This is the Hastings Center. So we used what we would call a modified Hastings protocol, which involved giving IV fluid boluses throughout the day and night if you could, several of them. Also giving antibiotics. And all that came from that one patient who was evacuated from to Germany, who had an episode of gram-negative septicemia. So one patient developed a bloodstream infection from a bacteria, and then we all kind of assumed, well, that may be how patients are dying. So we gave antibiotics to the patients along with antimalarials. Everybody got treated with antimalarials, IV fluids, some pain medicines, and antibiotics. I think the real heroes of the outbreak are really the local healthcare workers. So this shows one of the sprayers washing one of my colleagues' hands with chlorine, which is something you do many, many times a day. But the sprayers, the nursing techs, all those are really like brave people. Most of them have left their communities because they're, did this work kind of in silence, in a sense, because they were afraid that their communities would ostracize them if they went back after having worked in the Ebola units. Most of them were promised about $100 a month for hazard pay, but only got $20 or so for issues that are complicated, but not uncommon in West Africa that healthcare workers go unpaid. So they threatened to strike, but never did. So I think very brave people, and they would work much longer hours than we did. This is me inside the unit. A couple things that you'll notice. I'm like covered in sweat. After coming out of the PPE, you're literally like drenched in sweat. We did 2 shifts, 2 turns through the ETU for every like 8-hour, 10-hour shift that we did. Sometimes 3 if it was a quick activity that we had to do, like move a patient or do an admission. But typically 2. They would last on the order of 1 to 2 hours, occasionally a little longer, but it is really, really hard to stay in much longer than an hour in these suits. Some days the temperature got up to 40 degrees Celsius, which would be 104. So if you put on PPE and 104, it literally 104 degree temperature. It's like working inside a sauna. So when we would get out, we would drink oral rehydration fluids, the same kind of stuff that patients would do. Would drink, and you could drink liters of this, and but it would keep the blood pressure up and keep you feeling okay. And then get something to eat, do some charting, and then start mixing medicines and do things so that when we'd go back in for the second round, gathering food, diapers, baby food, all that kind of stuff that we would have to do. So a lot of work to do. Also, night shift, you saw the people dancing in the last slide. The night shift was kind of more pleasant because it was a lot cooler. You could stay in longer. The trade-off was that it is really hard to see, so you can't start IVs at night. It's really difficult to do that. So we would have to rely on like IOs, intraosseous lines, or subcutaneous fluids if there wasn't an easy IV site, if somebody's IV came out. And we'd take in like these checklists of things to do, but oftentimes there was like so much work to do that even with a big team, stuff would not get done. So we'd have to prioritize it every time in, what were the most important things to do, and then try to get them done. And this is a way that we'd kind of communicate so we could come back and chart, because anything that goes in the unit has to stay in there. You can't take anything out. So it all kind of gets burned. So we would tape it to the fence and then kind of see what was left over for our next to-do list. We did have this, shows some electrolytes. We had an iStat machine, which is a blood chemistry machine. But that really only worked during the cool times of day and night, so early morning. Just a few things on taking care of kids. I'm a pediatrician, so Most of the care that I did was with kids because we usually had enough kids, almost always. But a few things about kids. They're not the highest risk group for contracting Ebola virus, but we know that they generally have a much poorer outcome. Disease progression is much more rapid in kids. They have onset of fever quicker. They progress to wet symptoms. Rather than 4 days, they'll be like 2 days. And progression to death occurs much quicker in kids. The case fatality rate for the youngest kids, so kids under a year, is essentially 90% or more. So most young kids would die. And I think we discharged one 13-month-old child during the time that I was there for 5 weeks. But quite a few of them died. So it was really sad and really difficult on healthcare workers and staff when they would lose a kid, which unfortunately was the routine for kids under 5. So this led to a lot of like ethical and professional challenges. One of the things that came up all the time is allocation of scarce resources. So we generally had enough medicines and IV fluids. Sometimes we lacked additives like potassium, but we had generally enough of those. But what oftentimes was lacking, especially as case numbers were high, was the amount of time that you could spend at the bedside. So, taking care of like a dozen or 14 kids, trying to do that in an hour or so. Even in the U.S., in a cool environment, it's difficult to do that. But in a resource-limited setting, it's really difficult. Family separation was a big issue. People would have to leave their villages or their towns. They would be scared. They would have to be separated from the rest of their family. And the sense was that if they went to these units, oftentimes that it was a death sentence because they knew that the fatality rate was so high. Family separation came up all the time. People would want to leave. Some people would, a few people tried to hop the fence or did hop the fence. But we'd also have cases where there was kind of a discordant pair where mom would test positive and have to go to the confirmed unit, but the baby would not yet test positive. And then what would you do? So we would have to make ethical decisions if the mother came back to get the baby and take them to the confirmed unit, or the child was old enough to wander over there. What would you do then? So that came up actually pretty frequently. And then caring for infants and kids was quite difficult. They would oftentimes arrive alone. Staff couldn't stay in, full time to feed them and to take care of them. So we would, unfortunately have to just leave them alone or with an older child to take care of them. And sometimes the other older child would be sick. So it was really a difficult environment for everybody. We also had to make palliative care decisions. And this came up quite frequently, when we would have disagreements about what the goals of care should be for patients as they got sicker, because the case fatality was, as patients progress and you notice that they become disoriented, it's pretty clear that most of those will not survive. So at what point do we kind of transition to palliative care? There would be disagreements among the staff, and we would try to talk things out and figure out what to do. But those sort of decisions were difficult. And there were cultural and language differences. Inside the unit, there would be people that spoke English, Creole, Temne, like a local language. But also we worked with Cuban nurses and Cuban physicians. And so their English was limited too. So there was communication barriers and cultural differences. And then there's always sort of this constant worry about your own safety. Having to make decisions about should we start an IV? Should you hold kids or pick them up? Because I've known people that got exposed because children would reach under masks and things like that. So those sort of personal safety issues kind of weighed heavy. And then what Partners in Health and other people have termed stupid deaths, things like where people would get put in the unit because they met case definition. They had abdominal pain, vomiting, maybe fever, but it was pretty clear when you looked at them that they did not have Ebola. They had bowel obstruction, or they had, a pregnancy complication. And so watching people who did not have Ebola, kind of languish in the unit while waiting for a test that, took 2 or 3 days to rule them out. And so we had several patients that died of bowel obstructions inside the unit. And those are just things that don't happen if you have a strong healthcare system. So people ask me, well, where did you stay? I had actually pretty nice accommodations. I stayed at a Danish provider camp. They ran this international facility, so WHO workers, CDC workers, and NGO workers stayed here. I think it had about 200 people, air-conditioned tents, great Wi-Fi, so I was able to Skype with my family, which was really very nice.
Right.
So it was not compared with prior deployments that I've done. This was actually very nice housing. So this is a group of healthcare workers that I deployed with from around the U.S. Probably the best description of them that I have read was mid-career health professionals with a higher than average risk tolerance. So
Amen to that.
Yeah, so most of them had done like international work a lot. Many had done a lot more than I had, and had experience in field situations. So everybody was pretty comfortable with that. When I would get out of the unit, I like to run, and that's one of the stress releases that I had, was running all throughout the district. So with WHO workers or other people, and the kids would run alongside us. But the thing that I found most helpful is that it kind of helps put it all in perspective. So to help me see that even in the midst of this horrible epidemic, most people don't have Ebola. Most people are healthy, happy, just carrying on. But the kids were all out of school because they weren't in school at that time because schools were felt to be too dangerous as a source of transmission. So that was a great stress reliever. The other pillar is contact tracing. You all work for ADPH or for public health, so you know more about this than I do. But basically, contact tracing involves identifying who might have Ebola, who does have Ebola, following them throughout the 21-day period when they could come down with symptoms, and following if they do come down with symptoms, finding who their contacts are and tracing them, so kind of carrying on. And that really is the cornerstone of how this epidemic got under control. One of the things that struck me is this clustered transmission that was seen there, where it's this really complicated contact tracings, where they're usually involved a unsafe burial in a community involving traditional healers, and then people would travel to other communities and then transmit to family members. So that was the typical way that people got sick during the time that I was there. The final pillar is social mobilization and community engagement. And this was a storyboard that the Ministry of Health made to kind of talk to people about increasing their willingness to communicate if they had an ill contact in their community. So this is a child that I took care of for a couple weeks, and he and his family allowed photographs and all that, so that's why I have that. But you can see, so he got sick, everybody was very worried about him. A surveillance officer came out. Now, the surveillance officer would be in full PPE, almost certainly. And then they brought him into the treatment unit. Everybody in the community is, of course, very worried. And at the treatment unit, The doctors and nurses waited for them. That's typically how it occurred. So we would receive ambulances, a few walk-up patients, but almost all patients came in as suspect patients from ambulances. And then starting IV lines, giving oral rehydration to people who can take fluids, giving antiemetics, helping them to their bed in the treatment unit, and then providing nutrition, fluids as best we can. And then here he got better, and then you'll see what we had called the survivor's tree. So as people were discharged from the unit, they would put a little ribbon up there. So that's all the survivor's knots. And then reintroducing people back into the community. And we had psychosocial workers who were employed by Partners in Health, and they were really instrumental in reintroducing people back into their community. So in trying to decrease the social stigma of having this disease. So, and again, trying to convince people that they should report cases. Okay. I had 3 days off in 6 weeks, so I went to the beach and learned to fall off a surfboard. So,
and found some dogs, looks like.
I found some dogs. Yeah, I missed my dog a lot. Yeah, but it was actually pretty. It was in the beautiful beach, so that was a good stress release. So we had to take a day off like every 2 weeks. So everybody did. During the time that I was there was a lot of occupational health issues. The Cubans provided, I think, upwards of 400 healthcare workers to West Africa. During the time that I was there, one of them died of malaria in Sierra Leone. So, it wasn't just Ebola that was kind of a concern there. So we took anti-malarials. But during the time that I was there was, I believe, 3 healthcare workers that were caught Ebola. One was the Scottish nurse, but you'll notice in the headlines sort of a blaming of the healthcare worker, which I think is very unfortunate. After I left, there was 2 healthcare workers in the unit that I worked at Maforki. One was a Sierra Leonean house officer who contracted Ebola inside the unit. And then a couple days later, an American who worked with the organization that I did caught Ebola. And then there was an issue about differences in care. The American initially went to the British-run Ebola treatment unit for healthcare workers, and the Sierra Leonean was transferred to a general Ebola treatment unit. He eventually was transferred to the British-run unit. Both survived, but the American had a really rocky course. I think was on dialysis and in critical care, intubated at NIH for about a month. The investigation into the infections, the nosocomial infections, kind of pointed out some things that we oftentimes see after disasters and disaster response, kind of an unclear chain of command at the unit, lack of oversight on some of the doffing and donning processes. Those were the main issues that kind of came up. But I'll just say that those weren't unique to the facility that I worked at or the group that I worked with. And it's really important, I think, to remember that we were working alongside national healthcare workers, and this was a national Sierra Leone-run facility. So the amount of oversight that an NGO has in this situation is somewhat limited. So you all are probably familiar with some of the Ebola, post-Ebola syndrome, because it's been in the news recently. But what we found is that healthcare, or people who've had Ebola, now there's 17,000 in West Africa who've had Ebola, experience high rates of what's called a chronic disabling fatigue, reactive arthritis. They report neurocognitive deficits, problems finding words, problems thinking clearly, ocular problems, uveitis, and sexual dysfunction. But also, we know that sexual transmission occurs now. There's several really good case reports of people in West Africa that have contracted it through sexual contact with a survivor, typically a male survivor. Now, Liberia was declared Ebola-free on Mother's Day, and after going 42 days without a case. And then after a couple more weeks, they had a case that was almost certainly sexually transmitted from a male survivor. So what we think is happening is that the virus is hiding out in immune privileged places in the body, like the testicles, the joints, and the central nervous system. There's also a concern that there's a lot of social stigma in these countries now about towards survivors, whether or not they could be contagious. It is almost certainly the case that they're not contagious apart from sexual transmission. And the length of time that males should abstain from sex or use condoms is now considered like indefinite. It was 6 months, but I don't think people have a really good answer for that quite yet. And then this whole issue of reactivation, which came up with the Scottish nurse who had what is probably a reactivation or a viral meningitis several months after clearing her viremia. So I believe she's still in care in Great Britain for this, and whether this is autoimmune or whether it represents a true reactivation, reemergence, I don't think is really known yet. The case hasn't been described well enough yet. This is a case report from New England Journal about a pediatric infectious disease doctor who contracted Ebola in Sierra Leone. He cleared the viremia, but 2 weeks later he had active replicating virus inside his eye. He eventually cleared it with antivirals and steroids, but again that shows that the virus can persist in immune privileged locations for quite a long time. Just a few points on coming home and quarantine. All healthcare workers, everybody who came through the 3 most affected countries had to come through one of 6 designated airports. There we'd meet with a CDC health officer who did risk stratification, identified people as either no risk, low risk, some risk, or high risk. And then we had 21 days of active monitoring. And for people in the low, some, or high risk group, it was typically direct active monitoring where they'd meet with a health officer either through telemedicine or face-to-face. We're given a thermometer, a cell phone, and a symptom card. And all this was done through the state and local health departments. But one thing that I'm sure you're all aware about is a wide variation in monitoring strategies. So my friends who worked alongside me and had the same risk status, which is the some risk group, coming back, meaning that we were treating patients, but we didn't have any breach in PPE or protocols. So we were in the some risk group. Now those people would get an escort from the airport in New Jersey to their apartment, and then had to stay inside their apartment for 21 days. Wow. Whereas people in Washington were able to go to restaurants, go skiing, just phone in. Yeah, so there's a sense of fairness or equity, in a general sense that there was really a lack of evidence behind what was going on. So wide variation in monitoring strategies. So there were 28 countries in this. This is a Save the Children report. 28 countries that have weaker health systems than Liberia. Liberia is considered the strongest of the 3 affected countries: Guinea, Sierra Leone, Liberia. Liberia has the strongest health system. But there are 28 other countries around the world that are weaker, including large countries like India and Pakistan and Nigeria. And some of that is because the health systems are felt to be less fair, that people who have access to resources, live in large cities, actually get pretty good care, but people who live in rural areas or poor get very poor care or no care at all. So how do you strengthen a health system? So Partners in Health talked a lot about health strengthening, so this is health system strengthening. So looking at what WHO says, the 6 pillars or building blocks of a strong healthcare system. So the way to strengthen a healthcare system is to improve service delivery, make service more available to people, improve the quality of service, the affordability, the availability, train a healthcare workforce, improve information systems, so disease surveillance, so you know what's going on out there, make medical technologies, vaccines, products available to people, keep the cost down, improve financing, so some people don't have to pay more than they can afford and other people don't pay anything, and to make that more level, equitable, and then also to improve leadership and governance. So if you improve any one of those, you strengthen the health system and you make it more resilient or disaster proof. So that's really the objective behind healthcare strengthening. That's what you guys all do day to day. So, and to some extent, I guess I do that too by training healthcare workers. So, how to fight the next epidemic? So, almost certainly Ebola will reemerge, probably a 40% chance or so that it will come back in these 3 countries after it's eliminated. Remember, it's still not eliminated from Guinea, and Sierra Leone will be declared Ebola free, I believe, on the 7th of this month, so in just 4 days. So watch the news. Yeah, that's a great milestone, really great, because Sierra Leone had the most cases of all of the countries. So it's a milestone. But in terms of fighting the next epidemic, it's generally felt by WHO, by everybody, that they were caught off guard, that too much was expected out of NGOs like MSF, that they couldn't really deliver, and too much was expected out of these healthcare systems that were weak to begin with. So WHO was a little slow to get involved, to declare a public health emergency of international concern. And there's been some reports that, if it had been done like a month earlier, that perhaps like 15,000 cases could, more cases could have been averted, okay? Or a delay would have resulted in so many fewer cases. It's unclear exactly how many cases were saved, but it's almost certainly the case that if it had been started a little bit earlier and ramped up earlier, that quite a few lives could have been saved. Just 1 or 2 sentences on kind of the media analysis of the West Africa Ebola outbreak. The bottom red line shows the U.S. media reports, and the top line is the case counts throughout the 3 affected countries. So what you see is it was really only when Americans came back with Ebola that we brought, that it came to the attention of the media. Although it was still a public health crisis and people were still dying in record numbers in West Africa. And even after it went out of the media cycle, after the November midterm elections, cases were still rising in Sierra Leone. So the media kind of missed that. This was kind of just to wrap things up. This is right before I left. I made a visit to the cemetery, and that was really kind of emotional to be able to see like all the patients that I took care of. So quite sad, but also feeling like I in some way probably made a small difference. So just to summarize things that I've talked about. So this is a disease of caregivers. We know that supportive care reduces mortality. How much is debatable, but probably about like 20% or so. The case fatality rate in the unit that I worked in was 52%. We think that for this epidemic, case fatality untreated is on the order of about 72 or 75%. So some reduction in mortality. With access to critical care, you'll notice that all the patients that arrived in the U.S. and got critical care in a timely manner survived. So critical care definitely works, but we don't have the resources, or we didn't have the resources in West Africa. Ethical issues occurred frequently. These were everyday occurrence, and were difficult to manage. Eliminating Ebola virus really requires responding rapidly, engaging local communities, and strengthening health systems. So that's all I wanted to say. And they're still not at 0 cases, so it's not over. The saying is you can't put out 99.9% of a house fire. You got to get the whole thing. So, and they're almost there. So, so keep your eye on it, because I think hopefully in the next few months they'll be down to 0, but not quite yet. So, with that, I'll take questions if you have any questions.
Thank you for your time.
My pleasure. Thank you.
I think I have one question. It's really just one that came into my mind over and over as you went through your journey. Would you go back?
Oh yeah. Oh yeah, I definitely would. Yeah, and one of the thoughts is, now we have 500, 600 healthcare workers in the U.S. who have responded or been trained and actually know how to do this. So there's talk about, having a deployable force either through WHO. But I definitely would. I felt, cautiously safe the whole time. And, again, I think it's one of those things that as you practice it and as you get better at it, you feel more comfortable at it, which is why the federal government has really instituted, specialized pathogen centers to treat this. So when they have healthcare personnel who do this, practice it over and over, it gets safer and safer. So apart from the initial healthcare infection in Dallas, which kind of caught everybody off guard, the hospital, clearly wasn't ready for it, initially. There have been no nosocomial infections in the U.S. or in Western Europe, to my knowledge. So this is best done by people who have experience and who train to do it. So places like Emory, NIH. So
and have the desire.
And have the desire and can do it safely. Yeah. Because that's key.
We have a question. I don't know if it's an email question or a phone-in question.
We do have an email question. Can you tell us a little more about some of the biggest challenges that you faced to ensure the personal safety of you and your colleagues, and what you did to overcome them?
That's a great question. We instituted like these safety checks during donning. So, we put on our PPE and then you'd have your partner look it over, and then somebody else who's not involved, like a nurse, would look you over and then put a hand stamp on if they felt like you were dressed safely. So having like an additional layer of check before you go in, and trying to always work alongside a buddy or somebody so that you can watch your colleague, to make sure that they're not doing something unsafe. And they talk about, like, in these specialized units that treat it, having family rules, so being able to interrupt care. If something seems unsafe, then you have to say, no, you need to leave. So if you see somebody with a little exposure, even if they don't feel like it's a threat, you still need to send them out. So being vigilant for everybody. So working as a team, taking responsibility or ownership as if it's like a family member, I think is really key. And then understanding the limits of your own tolerance. Probably, the kind of the scariest couple things I saw were one healthcare worker that had heat exhaustion and had a syncope. Things like that are really dangerous. So if you have a heat illness inside an Ebola treatment unit, it is that's very dangerous because you're highly likely to expose yourself. So being vigilant for heat illness, and then as doffing, going slow. Probably the best advice I got before I left was, somebody say, okay, doffing, treat this as your Zen moment. This is the moment where that's the only thing you're doing is piece by piece of your PPE. You're being mindful. You're looking in the mirror. You're taking off slowly. So go as slow as you need. Even if there's a line of people behind you to get out, you still need to take all the time that you need. So that was, I think, a very good piece of advice, just to always slow down, because the tendency is you're overheated, you're hot, you're thirsty, after an hour in there, and you want to kind of get out, but you have to really kind of force yourself to do that, to slow down. So those were kind of the main tips that I have, or that people have told me, and so.
Mm-hmm. The Zen moment.
Yeah, the Zen moment. It's kind of
moment.
where you're mindful of what you're doing, because we're oftentimes multitasking, talking to somebody, or thinking about something else, thinking about what you're going to do the next moment. But when you're doing PPE or you're doing something like that, you have to be right there then. So.
Focus.
Yeah, focus, exactly.
Any other questions? I don't think, yes.
I just wanted to ask, were you or your colleagues ever affected by the Ebola?
No. I knew that it worked alongside the Sierra Leonean who caught Ebola. I did not know the American, because that happened after I left. I did, essentially 6 weeks or a few days less in country, and that happened 2 weeks after I left. So I did not know the American, but I knew the Sierra Leonean who caught it, and I knew several nurses and one Cuban doctor who caught it in Guinea, and he came back to work in the treatment unit. So that we knew people, and there were nurses before I got there in late summer. There were quite a few infections in the unit. So one of the things that we really tried to do was to improve the infection prevention control, to decrease those infections, and those were all among Sierra Leonean staff. Now, there have been, I think, 881 healthcare infections in the 3 affected countries, and over 500 of those have died, and half have been nurses or nurses' aides. And nurses, if anybody knows, they do the work of taking care of patients, much more so than doctors. So when we worked as a team, everybody kind of tried to do everything. So most of what I did was nursing care. It was hanging fluids. I'm not the best at starting IVs. I started a few, typically in big people where I could see the IV the site really easily. But apart from starting IVs, where we tried to let the people who were best at it do it, everybody did everything. So it was primarily nursing care, because it's very protocol driven. One thing that I did a lot of was I put in a fair amount of intraosseous lines and taught a lot of people how to put in intraosseous lines, which are bone lines, because that, in my practice in a pediatric emergency department, the nurses are very skilled at putting in IV, so they usually get them in. But if they can't get them in, I can get an ultrasound machine and look for one, and can get it that way, but I can't do it in a treatment unit, so then you have to really go with a bone needle or an IO. And we put in quite a few of those. And I also taught subcutaneous fluids, which is, I think, a really good way to give fluids, especially in palliative care situations. So I did know people that had Ebola, that had survived Ebola, and of course took care of a lot of people that did not survive it. But so typically our census, if I mentioned it, was at Maforky was typically on the order of 20 to 40 patients. And then at Cambia, it was typically a dozen or so. But Cambia had a surge while I was there, so they had 12 admissions in one day, and then upwards of 20 patients. And because that area along the northern border with Guinea is still the area that Guinea has it. So, and people cross over all the time. There's no real checkpoints. People go across in canoes or they walk across, and so this is a very fluid environment, and part of that has to do with the social disruption from the civil wars that occurred. So it's a very complex healthcare environment, and I learned a lot by working there, and I would definitely do it again. And I think with the proper training and with the proper amount of caution, it is safe. And, hopefully that my hope would be that the attention that's paid to West Africa now helps improve and strengthen the healthcare system, because this is going to be a long-term effort. But a big lesson, I think, take-home message for all of us is that what happens in small, out-of-the-way places that nobody's heard about, like Gekidu, Guinea, has a big impact on us and on the whole world, because we're, it's really a global village now. So, we can't neglect even the most remote or isolated places. We have to worry what goes on everywhere now. So, because we're all interconnected. So between transportation and finance, it's a global healthcare system.
Becoming more so. I think we have one more question.
We do have a couple more questions, actually. Were there any returning issues for you socially or medically? And did you receive any training prior to deployment? Those are
we went. Again, before deployment training, we had kind of written materials to review, things about the country, and then a couple days in Boston where we mainly went over like protocols. And then inside the country, we did most of our training, and that was simulated environment, observed, donning, doffing, critiqued. So about a week or so of training. Ideally, it probably could have been a little more, but at some point you kind of need to learn in the environment too. So the first 2 days at the treatment unit, we were told not to touch people, just to hand out water and do things like that. But as the needs kind of grew, you kind of fell into the role. Was there a second part of that?
Actually, you took care of that.
Okay.
Is there progress with a vaccine for Ebola?
Yeah, and I think the recombinant vesicular stomatitis virus vaccine it shows great promise. Now, there was thought early on that just the traditional way that vaccine trials are done with randomized, double-blind, placebo-controlled trials would not give an answer in this environment. And so the trial that made headlines, I think about a couple months ago, was kind of a modified protocol where they separated people in Guinea to either receive the vaccine immediately or delayed. What they found, so after a case was identified, they would do a ring vaccination. So everybody who had contact with that index case would be offered the vaccine. So they would do it kind of in terms of clusters. So one cluster would get immediate vaccination, another would get delayed vaccination. And what they found is that there were 16 cases, I think, out of 4,000 vaccinations, 16 in the delayed and 0 in the immediate vaccination. So it is pretty strong data that the vaccine is almost certainly effective. So I think that that's added another tool to the kind of final stage to getting to 0. And it probably has helped Guinea decrease the last few cases, the transmission lines. So this one, that vaccination trial seems to be the way that vaccine trials will likely occur in these kind of disaster, resource-limited settings in the future because of ethical considerations with giving people placebos.
One more question. Do you keep in touch or receive updates from any of the families that you met in Sierra Leone?
You know, it was really hard to communicate with the families. I don't. I keep in touch with some of the volunteers, but that's a great question. I wish that I could have, but typically it was kind of difficult. I took care of mostly children there. You know, adults during the night shift we would take care of everybody, but during the days, because I was one of just a couple pediatricians, I felt like I was probably most useful taking care of kids. So, no, I kind of wish that I had, and you know, I know some of the healthcare workers, the Sierra Leoneans, but haven't kept up as much as I wish I could have.
Questions keep coming. Being a pediatric physician, can you tell us a little more about some of the key differences you experienced when treating children versus adults with Ebola?
Yeah. Well, like I said, kids tend to, they're less likely, you know, 3 to 4 times less likely to get Ebola than adults do, because children aren't, they don't take care of sick people for the most part. As they get older, they, you know, take on adult responsibilities, but it's a caregiver disease. So most of the kids that I saw got exposed either from family members or at funerals. And taking care of kids, you know, they're like, you know, there's some technical challenges, like IVs are difficult to start. There's the whole issue of how to best, you know, administer fluids to kids in West Africa. If people are familiar with like the FEAST study, which kind of looks at differences in outcomes with kids in Africa who get IV fluids. So malaria is very high. So most kids have malaria, you know, or have had it at some point. Many of them are anemic because they've had malaria or have it currently. A fair number of them are stunted. Probably half or more have some growth retardation or stunting. So I showed the picture of the child that I took care of, and you know, it kind of surprised me that I think he was 12 years old. I would have guessed, you know, looking at him, that he was on the order of 8 or 9. So you'd typically see shorter stature, and that's oftentimes nutritional. So, but other issues, you know, a lot of them just wanted to be held, you know. There's some thought that it's kind of more dangerous to hold kids because they can be unpredictable and reach up and expose you. But everybody that I knew kind of did that and spent more time and, you know, tried to comfort the kids. They probably had, as the disease progressed, it progressed a little bit quicker. What we would oftentimes see is that kids would sort of rally with initial fluid resuscitation. They would get better and do that for a couple days, and then, you know, and maybe start to eat something, and then just sort of peter out. And it's not really clear why. You know, they would get sicker as you know, after a week or so, but then oftentimes have seizures and become, you know, unresponsive. And then at that point, you know, it's kind of palliative care. But you know, when we did have the kids that would survive, it was kind of a big success, and it really rallied everybody. Because people, you know, I guess in terms of fairness, and people have an easier time sort of, you know, bonding, I guess, with a lot of the kids. So, but yeah, those were some kind of take-home points.
I think that would break my heart.
Yeah, and you know,
Questions?
when we would lose IVs, we would oftentimes go to like subcutaneous fluids or intraosseous lines. But unfortunately, you know, in almost all those cases, I think the outcome was pretty poor. There is a case report of a pediatric critical care doctor who was with a group that I worked with that put in an intraosseous line in a child. He was there before I think a 1-year-old that survived. But we would still see problems like seizures and developmental problems in that follow-up group of young kids who survived, because it's a terrible disease. It's an awful disease. So Yeah, and I don't think we know anything really about, the long-term outcome of kids who've had Ebola but survive. I think that's a big question mark. People just don't know.
All right. Well, we've got one more thing that we want to do that's very, very important, and we want to thank you very much for your time and for your ability to come and share with us.
Okay.
And it is...
And on behalf of Alabama EMS for Children, I would like to present this to you, Dr. Baker.
Oh, I thank you. That's
Appreciation for all you have done for the children of Alabama.
Why, thank you, Catherine. That's very nice. I appreciate that. And I'd just like to thank, when I came back, I think one of the questions was about, stress coming back. And I would just say that ADPH and Jefferson County Department of Public Health, they were very professional and, made me feel welcomed, and I thought that was great. And the way that they did sort of the direct active monitoring by coming to meet me at my house, let me come home from the airport, meet me at the house, talk to me, find out exactly what, they thought the risks were, and then coming up with a plan together that seemed reasonable, I think is really a model for the way that this sort of direct active monitoring should be done. So I appreciate ADPH for their professionalism and their help in getting through that period, and I can't thank you all enough. I thought it should be a model for other states to follow. So thank you.
Thank you.
Thank you very much for your time.
Thanks a lot.
And we really do appreciate it. Any other questions, comments, concerns? We want to thank Dr. Baker, let him get back to work doing his good deeds.
Well, thank you.
We want to thank everyone. The continuing education credits have been approved for nurses, social workers, and the EMS personnel for this program. In order to receive your credit for this training, you must complete and return the sign-in sheets and the evaluations after watching. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, and it will expire on November 30, 2016, which is 2 years for social workers, expiring on November the 30th, 2017, and 2 years for EMS personnel, expiring on November 3rd, 2017. Thank you for watching, and have a great day.